It's my pleasure to introduce Dr. Treon, who is the director of the Bing Center for Waldenstrom's Macroglobulinemia at the Dana-Farber Cancer Institute in Boston, USA. He is a global figure in the search for better treatments, methods, and an understanding of the disease with a view to an eventual cure. And aside from the clinical aspects of huge amount of experience in treating patients, he's engaged in vital, basic, advanced, and translational research, which is focused solely on WM, through genomic researching, and then the focus on a couple of very exciting entities, MID88 and CXCR4. And aside from national and global lectures and 160 original reports, 24 book chapters and editorials, and probably close to 200 abstracts, he has been a guiding force in the development of awareness for this rare disease throughout the medical profession as well. So we're really privileged to have him here, and we look forward to what he has to say. Steve, thank you.
Thank you, Shirley, and it's I that am privileged to be here with you and to be able to share with you so much of the progress that has been going on in this disease, and also to share with you all the things that we learned this past week here in London at the 8th International Workshop on Waldenstrom's Macroglobulinemia. So there's a lot to report to you, and I'm going to get started here just so that I have the time to do so. So I was given the task of giving you an update on the genomic and treatment advances related to the advances in genomics that emerged from this workshop. And I am pressing every forward button I can find, but nothing's moving. This one? Okay, great. All right. We all know where we are, right? So the problem with Waldenstrom's therapy to date has been that we wait until our myeloma colleagues or our lymphoma colleagues or our CLL colleagues come up with therapies, and then we eventually get them and test them in Waldenstrom's. And many times there can be a real big delay, to seeing some of these drugs get tested because things get prioritized. And when you're the orphan, you always end up, being forgotten. And so it's been important for us to get at the heart of what we believe is the reason why Waldenstrom's cells have gone bad. And in our laboratory, we embarked on something called whole genome sequencing. It was a very bold effort, and because many different ways of trying to figure out what caused Waldenstrom's before us, including efforts in our own laboratory, really didn't give us much insight. We had some idea, but never the idea that came out of this particular effort. And when you talk about whole genome sequencing, this is an effort where you basically sequence every single DNA molecule in a cell. And cells have about 3 billion of these DNA molecules. And what we ended up doing is not only taking the DNA from 30 Waldenstrom's patients' tumor cells, but we also took the DNA from their normal cells. And that strategy is what paid off, because what we were then able to do, using very advanced, computer algorithms, was be able to line up, this data and look and see, where potentially a mistake would have been. And that effort really belongs squarely on Zach Hunter, who was really a phenomenal mathematician and also had the molecular biology skills to be able to do this lineup. And we also had another group that we had given the data to simultaneously in hopes of being able to see, whether one group had an advantage over another group because they were going to use, a different algorithmic approach. And as it turned out, both groups independently came up with the same answer. And that answer was that there was a mutation, a single point mutation in the DNA, one single DNA molecule out of 3 billion. But that mutation was recurrent, and we saw it in over 90% of the patients that had Waldenstrom's macroglobulinemia. And we then went on to confirm those findings. We ended up using a different type of technology because you can't put all your trust in one type of technology because they're all prone to error. And that too came up with a same kind of answer. And then we, and many others across the globe began to look at even, more advanced technologies to see if, in fact, maybe we were missing some cases because the kind of technology that we had used up to that point, whole genome sequencing and something called Sanger sequencing, you still needed about 10% of your bone marrow, maybe even 20% of your bone marrow to flush it out. And so we ended up using something called PCR technology, which I'm going to get to in a moment, but it has a sensitivity, down to 1 to maybe 5,000 cells that you can actually flush out a bad cell. And with that in mind, the rate of individuals that had the mutation went up even further. And this is just a small handful, I'm going to say at this point, of studies that have been published on this subject. Over 26 papers now have been published on the mutation of, let's see if this works, yeah, on the mutation. And not only did we find the Waldenstrom's cells to have this mutation, but we also looked at patients that had the precursor condition of Waldenstrom's, something that we called IgM-MGUS, and Dr. Kyle by far is the individual who best understands this particular entity. Anywhere from 50 to 80% of individuals had the mutation, meaning that this is likely to be an early event that ends up driving, the cells to grow and survive. In my laboratory, Lian Zhu, who presented here at this meeting, went also to work trying to see if we could use the MYD88 discovery to separate out Waldenstrom's from other diseases. And this was a really critical exercise, and ultimately what won us the New England Journal paper acceptance, because for many years it had become problematic to separate Waldenstrom's from other very closely related diseases. And so the pathologists were also after other tools. And what you can see here is that these are called violin plots, and actually the lower the score is, the more likely it is that you're positive. And you can see where all the Waldenstrom's people are, very, very strongly clustered. And then you look at these other entities, like something called marginal zone lymphoma, which looks very much like Waldenstrom, but you'll see that most of the cases are negative. There's 1 or 2 here, but these turned out probably to be Waldenstrom's cases. If they had walked into my clinic, we would have called them Waldenstrom's. In myeloma, we found, that these were all negative, including cases that make IgM. In CLL, only 1 out of, I think, 26 patients was positive. And here's the IgM-MGUS. You can see where the line here is drawn, with about half the patients being positive. But those that were strongly positive went on and became Waldenstrom's patients in due time. Now, we also heard at this meeting work that was done by the Italian group led by Marcia Veritoni. And I'm going to just summate this slide without dragging you through every bit of detail. But what she found was that if you had IgM-MGUS and you had the MYD88 mutation, you were more likely to go on and develop some type of malignant process. More commonly, it was Waldenstrom's, but also there were individuals who developed marginal zone lymphoma. So that's a very important story, to tell us that, in fact, you might be able to use this kind of technology and the detection of the mutation to help you at least identify who's at higher risk. And maybe today that really doesn't mean a lot to us because, we still don't treat people, at that early phase of detection. But in due time, it may become a strategy where we can, go after preventing the emergence of Waldenstrom's, if you can identify who those high-risk people are. Now, this is probably a slide that most of you in this room will probably get very excited about after I tell you about it. And this is an effort to try to see if you can detect the MYD88 mutation by a simple blood test. And in fact, it turns out, and these are all the Waldenstrom's patients here, smoldering means asymptomatic. Symptomatic, of course, is clear. These are patients that have been previously treated, and here's your IgM-MGUS. And in this particular exercise, blood was taken, the B cells were isolated, and MYD88 was checked. and then compared to bone marrow. And what you're going to see here is that these numbers are actually stratifying almost identically, meaning that they have very high concordance with the exception of the previously treated patients. And in this case, about 60% of those that are positive in the bone marrow can be picked up by, blood. But among the untreated individuals, whether they're smoldering or symptomatic, it's about 98%. So meaning that a simple blood test, extracting out the blood and getting those B cells, could potentially allow us to identify MYD88. And even more to this work, which I think needs to be cultivated. Today is not the right time to say that we're there, but probably with some more studies we can get this, that it may be possible that we can even avoid in the future, solely relying on bone marrows, to make the diagnosis. In the right clinical setting, just a blood test may be helpful enough to be able to tell us who's got Waldenstrom's and who doesn't. That kind of work, I think, needs to be cultivated still, but we're probably not that far away. Okay. So, and I just said that, so we're going to move on. All right. Now, is MYD88 enough, to cause Waldenstrom's? We're not sure. In fact, the more time that has gone by and what we learned at this meeting is that it's probably an early kickstart to Waldenstrom's. And there are probably other mutations that come along, maybe facilitated by the MYD88 mutation, that are ultimately important to helping get that engine revved up. And again, I don't expect you to decipher all that's here, except, this is Zach Hunter's work, and I'm sure he touched upon this, but there are other mutations that we have found that actually segue with the MYD88 phenotype. And we think that these ultimately will be important to characterize, not only to give us a better understanding of why the Waldenstrom's disease, emerges, but also, why it is that some people respond to one type of, agent versus another, and why some people, develop certain aspects of the disease. Now, back in our center, Dr. Ruben Carrasco received a very generous grant from the IWMF that was actually mainly funded by IWMF Canada, but in conjunction with IWMF International. And the purpose of this work is to be able to figure out what those other mutations are that help drive along the development of Waldenstrom's. This takes a little bit of time. What you do here and what we did is we put together the constructs that allowed us to put the human MYD88 into mice. And then Dr. Carrasco developed these transgenic mice, which are supposed to reconstitute what happens in human beings. And it takes time because the animals have to mate, they have to grow, you have to expand the colonies, and then it takes time to sit on these mice in order to be able to see what ends up emerging. But we're into our second year at this point in time, and we do know that the human MYD88 molecule is being expressed in these mice, and time will tell us, what will emerge out of these studies. But these are the kind of critical studies that you need to do to then be able to realize what the additional mistakes are that help, propagate the Waldenstrom's macroglobulinemia. Now, turning to functional studies, because one of the key elements when you, find a genetic mistake like this is to try to figure out what does it do and how you can stop it from doing it. And this is actually from our New England Journal of Medicine paper, where we ended up using an inhibitor that actually blocked MYD88. And the way it blocked it is that for MYD88 to work, it actually has to undergo something called homodimerization. Fancy word for saying two molecules of MYD88 have to come together. And that adjoining is what then allows for the signaling to take place. And this was actually a molecule that was commercially available that actually blocks that homodimerization. And when that happens, what ends up happening to the cells, all these little green dots that you see, first of all these blue things that you're seeing here are the nucleus of the cell, the command center of the cell. And when you see the little green dots, it means that this precious molecule called NF-kappa B is actually there. And NF-kappa B is what's keeping things going. It's actually the machinery, the protein that creates the machinery to keep these cells growing and surviving. And if you add in an inhibitor, all those little green dots go away. In fact, what you end up seeing is no longer are they in the cell nucleus, and these are two different cell lines that we used, one from our center, one from the Mayo Clinic, from Dr. Ansell's group. But when you add the MYD88 inhibitor, the lights are out. You don't see them in the nucleus anymore because the NF-kappa B doesn't get there. And that actually excited us more than anything else to be able to show these figures. And we saw this also in patient cells when we added the MYD88 inhibitor, because if we can turn the lights out in the nuclei, we're on to something. And that becomes the challenge. How do we turn the lights on? Okay, I'm going to learn to push the right button this time. So Dr. Guang Yang in our group, who also presented his data, went to work to try to figure out, what were the signaling pathways, what was the electrical circuitry that kept these cells alive, and how we could turn those lights off. And so he made actually a very dramatic discovery while he was working on this, and he discovered that Bruton's tyrosine kinase, BTK, we're going to hear a lot about BTK, was actually one of the molecules that was actually tripped by MYD88. And that there were actually two different pathways by which MYD88 can actually signal. The traditional way, which is the Iraq pathway, and notice it's IRAK, not Q, and nonetheless still problematic. and you can either signal the cells to excite NF-kappa B through the Iraq pathway or through this BTK pathway. And what he also learned is that they're independent of one another. If you block Iraq, you don't affect BTK, and if you block BTK, you don't affect Iraq. So the challenge now becomes, how do we shut down, the circuitry so we can shut down all the MYD88, signaling? And so this was the work that actually proved that that BTK switch was turned on by MYD88, and I won't get into the details, but suffice to say, what he then was able to show is a drug like ibrutinib, which tackles BTK, it binds to BTK and shuts it down, actually selectively killed off the Waldenstrom cells that had the MYD88 mutation. And so all of a sudden we had a drug that could go about extinguishing at least part of the MYD88 pathway. And so many of you may know about this drug, but I want to spend a little bit of time because one of the big stories out of IWWM8 was, in fact, the recent study of ibrutinib in patients with previously treated Waldenstrom's macroglobulinemia. And ibrutinib is a drug that actually binds and inactivates BTK. It's an oral medication. It can shut down BTK for about 24 hours. You have to worry a little bit about this drug because there are a number of drug interactions. You can't be on Coumadin, which is a blood thinner, and overall well tolerated, as I will show you. And so this drug is approved in the United States now for CLL and for mantle cell lymphoma. And in Waldenstrom's, as I will, I'll show you the data, it has received what's called a breakthrough designation, meaning that between the science and the early clinical results, the FDA is very interested in seeing to its approval process. And so we launched a clinical trial looking at this agent. It was a trial that was open at Dana-Farber, Memorial Sloan, and Stanford. And the patients got 3 pills a day. Those 3 pills add up to 420 milligrams a day of the drug, and they could stay on as long as they were tolerating it and that they did not show evidence of progressive disease. These are the key criteria for being on the study. You had to have at least 1 prior therapy, and you also had to have decent blood counts, no central nervous system disease, so no Bing-Neal syndrome, and no Coumadin use, as well as drugs that can affect heart rhythm. And this is actually the characteristics of the patients that were on the study. And I should say we had 2 patients out of the 63 that were UK nationals. They actually flew over and they were part of this clinical trial. Their median age was 63. They had 2 prior therapies, and they were relatively sick because when you look at, the bone marrow involvement, it was 70% involved. So it defines a very, very sick group of patients. And on top of that, 60% of the patients had enlarged lymph nodes. These were the reasons why we treated the patients. 90% of the patients required therapy because they were symptomatic from anemia, and another third, and multiple reasons could apply, had also enlarged lymph nodes or some other type of disease outside of their bone marrow. And a few patients actually had neuropathy. The IgM was causing a neuropathy, which is quite common in Waldenstrom's. This shows you some of the data that was, that's now been generated and will be submitted for publication. But with about a year's worth of therapy on average, you know, what you're seeing here is the IgM levels for all the patients, and you see this rapid drop-off, especially within the first few weeks of therapy. In fact, the median time, meaning the average time to a minor response, which was 25% reduction, was 4 weeks. And in fact, by 8 weeks, that was the average time to getting into a major response. And so these are very quick dynamics. And more impressive than that slide is really this slide here, seeing what happens to the hemoglobin. And, you know, all these things are going up because hemoglobin is improving. And in fact, the average improvement was about 3 points on the hemoglobin. And within the first few weeks, you knew you were onto something because the patients would come in feeling much better. You know, their hemoglobins were up. And I think the best tribute that was given by one of my patients was, you know, he lives up in New Hampshire, you know, near Mount Washington, where they get lots and lots of snow. And he said, I'd given up, you know, shoveling snow for several years because I was always tired. And, you know, the year after he had been on ibrutinib, he sent away the boy that was doing all the snow shoveling for me, and he's been doing it ever since. So he put that person out of work, but he put himself back in. And I think that's really a good testimonial of how patients have done with this therapy, without exaggerating. This shows you what happens to the bone marrow, and it's very critical for us as a community to be critical of, you know, these newer drugs, because many of them can make the IgM go down. Few of them, if any, ever affect the hemoglobin, but some of them actually don't touch the bone marrow. You know, we saw that with our trial with everolimus. And this shows you that there was reduction in the bone marrow from 60 to 30% at 6 months, you know, time. But there's a story behind this which is important to share with you, and that is that for a few people, when you look at the pre and the post, you know, bone marrows, there really wasn't much change in the bone marrow. They didn't progress, but on the other hand, they didn't regress. And yet these patients still had clinical benefit. Their IgMs went down, their hemoglobins went up, they felt better. And so this is now telling us a little bit about other mechanisms by which ibrutinib might work to improve on these parameters. The good news is these patients haven't progressed. And it's making us now rethink the way we should be defining clinical benefit for agents like ibrutinib. This also shows you what happens to their lymph nodes, and you can see here that, 60% of the patients had improvement in their lymph nodes. Another third of patients had stabilization. With regard to improvements in peripheral neuropathy, I mentioned that this is a problem that we see in a lot of Waldenstrom's patients. Out of the 9 individuals that had neuropathy related to their IgM with Waldenstrom's, 8 had a major response, 1 had a minor response, and 5 of those individuals, reported improvement in their neuropathy. 4 were stable. The one issue about treating neuropathy is that the longer the time goes by that you've had the neuropathy, the harder it is really to improve. And one of the things that we've learned from some of our studies is that earlier may be better. These were patients, again, that had been previously treated and had the disease for a while, so I'm not completely surprised by the fact that some people didn't have improvement. And if anything, we really now should be thinking about this as a community, to moving this therapy further up for people, not only for people with Waldenstrom's, but in particular for this group of patients with IgM neuropathy. This shows you the best clinical responses to the ibrutinib. 87% of the patients had a response, major response, which is a 50% improvement in the IgM, occurred in 70% of patients. There were no complete responses, meaning no one went away with a complete response to ibrutinib. Now, I also like showing this slide for a reason, because when we try to do a subset analysis of patients, there are always some things that traditionally we look for to see if the drug is really working as well as it is, or if it's in select groups of people that it works better. And we define relapse as being somebody who got treated before, they did well, and then the disease came back. Refractory means that they never responded even to that first therapy or second therapy that they received. We also look at the number of prior lines of therapy, the age, the IgM level, the bone marrow involvement level, and beta-2 microglobulin is a prognostic marker, and the higher it is, the worse off it is, but no impact on response with any of these parameters. So you could have had really one of these bad features and yet, you did just as well as the individuals that didn't have them. Now, as part of our efforts, we wanted to now apply the second most common mutation that we found in Waldenstrom's, and Zach Hunter should be credited for this because those computer algorithms that I talked to you about, before, both in our hands as well as in other people's hands that went through our data, they missed this one. And Zach, became very persistent in his search to try to identify other mutations by really looking at the mutational landscape in a very different way. And as a result, we were able to identify these mutations in the CXCR4 receptor. And these mutations, as I know you heard earlier, occur in this little pigtail, of the protein. So this molecule sits on the cell surface, but it's got a little pigtail that goes into the cell. And if you interfere with that pigtail, this receptor, has problems signaling. And there are many mutations, and I'm actually glad you can't read this because all it's supposed to make you think is lots of mutations, lots of work for Zach. And so we've identified over 30 mutations in the CXCR4. MYD88 is just one mutation, and there may be others in due time that may be discovered in MYD88, but CXCR4 right off the bat, over 30 mutations in CXCR4. So when we got this mutational data, we went to work in our laboratory and we wanted to screen a very large population of patients and to see what the impact clinically was on having the MYD88 mutation and the CXCR4 mutation. And this actually shows you some very interesting findings. What it shows you is that if you had no mutation in either MYD88 or CXCR4, you actually had very low disease burden. In fact, the average is about 15%, and you also had a very low IgM. But if you had the mutation in MYD88 and you had this very interesting mutation called a nonsense mutation in CXCR4, nonsense mutations are mutations where that pigtail gets cut off. I mean, it's like just putting like a scissor to it and cutting it off. These patients were the ones coming in with high burdens of disease and even very high IgM. If any of you have presented with hyperviscosity crisis, or very high IgM levels, you're likely to have one of these mutations. And then the other group was what we call intermediate, individuals that had the MYD88 mutation, but either were wild type or had this other type of mutation called a frame shift mutation. Frame shift means that the little pigtail is not chopped off, but it's just scrambled. A coding error has happened, so there's all kinds of scrambling going on in that little pigtail. Now, we also learned that lymph node distribution, meaning patients coming in with lymph nodes involvement, actually was much less for people that had CXCR4 mutations. And this actually makes sense to us because the CXCR4 mutations are mutations that favor homing into the bone marrow. So once again, making sense in terms of what we would have expected from lots of previous work. And more interestingly, when you looked at people with hyperviscosity crisis and requiring therapy, you were more likely, if you had that MYD88 nonsense, mutation, to be in this camp. So the take home from all this is, we are what our genes tell us to be. And in the case of these type of mutational patterns, they can actually very much tell us what's going on with the patient. Now, the one disappointment was that even though CXCR4 mutations coming in with aggressive disease might make you think these patients are not going to do as well, they actually weren't that badly compromised. Whether you had a CXCR4 mutation or not didn't really affect, outcome. It was the lack of having a MYD88 mutation. And this is a survival curve. And these patients were the ones that were compromised. So having a MYD88 mutation, and whether or not you have a CXCR4 mutation doesn't really affect survival. It's really not having a MYD88 mutation. And this is why, more than ever, we need to understand what is going on, with these individuals. If there's a priority for us as a community is to figure out what makes these cells tick. So I'm going to move on here because I think I've covered a lot of this, and I just want to now move on and talk a little bit about the impact of these CXCR4 mutations on ibrutinib. And what we discovered is and we'll go right to this slide here because for the sake of time here, is that if you have a CXCR4 mutation, it puts you, at least in the test tube, and I'll show you the clinical data in a second, it puts you at more risk for not responding to ibrutinib. And, you know, there's actually a double story to this. One is to recognize that the CXCR4 mutations impact ibrutinib response. The other is that we can actually potentially do something about it. And I won't bore you with this slide except to tell you that if you use a blocking agent to CXCR4, you can resensitize those cells that are mutant. And so this now shows you the outcome of the ibrutinib study. And what we're looking at here is the IgM levels in individuals following treatment with ibrutinib and looking at them based on their mutation status. And once again, if you were mutated for MYD88 but no mutation in CXCR4, you had the lowest reduction. If you had a WIM mutation and had the MYD88 mutation, you didn't have as robust of a decrease in your IgM. And this is actually those individuals that have no mutation at all, even less benefit. And the reciprocal was true of the hemoglobin. Again, if you responded, you got improvement in your hemoglobin. And this I'll show you now what happens over the course of time when the patients are treated. The ones that are in red are the WIM people. The ones that are in blue are the ones that don't have a CXCR4 WIM mutation. And you notice the IgM going down is much better if you have no mutation in CXCR4. It's less so for those individuals that have the CXCR4 mutation. And reciprocally, when you look at the hemoglobin, guess what? The individuals that don't have the mutation do much better. Their hemoglobins go up, whereas those that have the WIM mutation don't show that benefit. And part of that benefit may not have to do with what's going on in the cell, the circuitry effect of this mutation. It may have to do with the fact that when you have a WIM mutation, it tells you to go to the bone marrow and stay there. And when you look at this in terms of the patients who get ibrutinib, and you start measuring lymphocyte counts in their blood, well, if you have the mutation, you don't see any difference. And with ibrutinib, very commonly, you'll start seeing the tumor cells coming out of the bone marrow and getting into the blood where they become more vulnerable to being killed off. And the individuals that actually don't have the WIM mutation, they all show their lymphocytes going out. And so this may be part of the mechanism. And in fact, when you look at the exodus of lymphocytes, you're more likely to fall into what we call a major response camp. This shows you actually the tabulated results from the study. If you have a MYD88 mutation, major responses in 71% of patients, overall response 90%. If you have wild type, meaning no mutation in MYD88, it's much less for both categories, particularly for major responses, 71 to 29%. And the same is also true with CXCR4, except the degree of difference isn't as pronounced as those that we see with MYD88. The good news about this kind of therapy is that, you know, it's long-lasting. It's what we call durable. And at a year's time, on average, 80% of the patients still remain on therapy. And remember, thinking about the population that I told you about, heavily impacted with disease, 2 prior therapies, these are data that we can get very much excited about this particular drug. This is the side effect profile. Again, I'm happy for you not to see every single data point here, but I do want to point out there are people whose blood counts get compromised with ibrutinib, particularly the white count and the platelet count. However, these are patients that have had lots of prior therapy. That's an important determinant, and another reason why we should try to move this drug up front. Atrial fibrillation, where the heart goes into an abnormal rhythm. We've seen this in a few patients. It's now been described even in CLL patients, and this tends to occur in people that have already had a history of atrial fibrillation. It hasn't caused us to stop therapy even in these individuals. If you stop the ibrutinib, they go back into a nice normal rhythm, and then you just restart them at a lower dose. And I think in all cases we've been able to restart without any problems. You also have to be on the lookout for bleeding. If you're going to have a procedure on this drug, you've got to stop the ibrutinib and wait it out, do the procedure, and then come back on a few days later. And you can't be on a blood thinner like Coumadin. Aspirin so far has been okay, as well as some of the other substitutes for Coumadin that are out there. I just want to also show this data because I think this is a very important piece. Many people with Waldenström start off with low, good antibodies that protect them against infection. And many of the drugs that we use, even rituximab, can make those good antibodies go away, which is why patients with Waldenström's many times end up with recurring infections that are worsened because of the therapy. And when you look at ibrutinib, you actually see no difference, baseline to after therapy, no difference, in these levels. And this is really in contrast to many other therapies that we use. Now, one of the points that I mentioned earlier is that you can, see sensitization, to chemotherapy if you block the CXCR4 receptor. And that not only is true of ibrutinib, but you can see it with other types of chemotherapies, including idelalisib or CAL-101. So I think as we start to think forward how we can change, the paradigm for treatment for Waldenström's, part of that will involve having, efforts to stop CXCR4 signaling. And this is one of the trials that we will hopefully have up very soon, where patients who have the CXCR4 mutation will be treated with ibrutinib plus a CXCR4 inhibitor. I just want to move on now and talk a little bit about some of the new agents that we're hoping to bring forward. And I already mentioned to you the Iraq pathway. And Sarah Berlage and our colleague Nathaniel Gray at Harvard have been hard at work trying to develop inhibitors of the Iraq molecules. This has been a collaborative effort with Guang Yang in our laboratory. And one of the molecules that we've developed is this molecule here called THC2-118. And we've shown that this molecule can actually get into the groove of Iraq-1, very much enhanced for Iraq-1 inhibition. And what we've done as part of these efforts is to actually treat Waldenström cells from patients who have been on ibrutinib or not. And we've actually come to learn some very interesting things. One is that if you just treat people with ibrutinib, and look at what happens to their cells, you're going to get some degree of death. These are cell lines, but we have the same data with patient cells. But if you use this Iraq-1 inhibitor, particularly together with ibrutinib, all of a sudden the amount of death or chaos that you can create goes up dramatically. And so this is now giving us at least the impetus to try to combine Iraq inhibitors along with BTK inhibitors, because as I mentioned to you earlier, MYD88 signals through both of these. And if you can, shut down both pathways, you can make a difference. In addition, Guang Yang and our group showed something else that was quite interesting, and that is that MYD88 also has this other bypass way of signaling through PI3 kinase. And that's actually very interesting because PI3 kinase is in fact the target of idelalisib. This drug just got approved in the United States as well for patients with previously treated CLL. And in fact, A.J. Gopal at the University of Washington and his colleagues, have treated many patients with different types of histologies of lymphoma, including 10 Waldenström patients. And 7 out of those 10 patients actually showed a response, and many of them durable responses. And so this trial here, where we will be looking at idelalisib, which is given twice a day in relapsed refractory patients, will be moving forward this fall. And this will be a multi-center effort led by Jorge Castillo in our center. Now, I want to actually now talk a little bit about one other way of going about hitting MYD88. And that's not just trying to get at the bottom of MYD88, after it's already caused, the aberrant signaling, but to actually go after MYD88 itself. And Claudio Setti here presented a wonderful paper where he has been able to identify the way that MYD88 comes together or homodimerizes, back to what I was telling you earlier. And his work actually identified a critical residue called E183 that allows for this binding to take place. Now, we should all take note of this because this is public enemy number one as far as everybody in this room is concerned. 2 MYD88 molecules coming together, because this is how the signaling cascade for MYD88 begins. And so Xiao Lu in our laboratory, running with this, has been looking at ways of creating mini peptides that can actually get into that same groove and prevent MYD88 from coming together. And I want to show you her very exciting results. She's actually one of the most understated people that you will ever meet. You know, for all her brilliance and all her wonderful work, you know, she is really one of the most unassuming individuals. And so when she presented me with this, you know, in her humble, unassuming way, you know, I fell out of my chair. I'm not going to say I fell out of my chair, because she very nicely was able to show that, you know, you could shut down BTK, you could shut down Iraq, you could even shut down NF-kappa B. And more importantly, you could induce those cells to start dying, which is exactly what we had hoped to see. So not only had she validated everything that we had, you know, suspected, that MYD88 signals through BTK, Iraq, and this triggers NF-kappa B, but also show concurrently, you know, cell death. Now, why is this important? Because if you can figure out what that minimum area is, you know, that's critical, you know, for bringing these two molecules together, you can make something called peptidomimetics. In fact, there are many companies in this world that all you have to do is give them the little sequence of amino acids that you need to make, you know, that they need to make a drug against, and they'll go to work. They'll actually put, you know, supercomputers to work and actually generate structures, you know, and molecules for you to use. And this is the kind of thing that I think ultimately, if we're dreaming here about how we're going to cure, you know, this disease, this is actually a very rational strategy of getting to the heart of the problem. The last couple of slides I just want to show you is another way that potentially we can go about, you know, hitting Waldenstrom's. And as I alluded to earlier, just turning on MYD88 itself, you know, is probably part of the reason why Waldenstrom's cells survive. The other part has to do with this molecule called BCL2. When you've got forces at work that are trying to kill the cell, you know, BCL2 actually props itself up and tries to prevent the cell from dying. And so you've got this tug of war. It's almost the kind of tug of war that you see when the Bruins are playing Vancouver. And you may not know about, do you know about hockey? Do you play hockey here? There's a Canadian here. Are there any other Canadians in here? Yes, you know all about this, right? There's a rivalry here between Boston Bruins and Vancouver. In fact, you know, when the Bruins beat Vancouver, you know, we never expected our Vancouver, you know, compatriots to set fire to their own city. I mean, that's how serious they take hockey up there. But this really describes the rivalry between, you know, drugs that are trying to kill the cell and having, you know, a strategy to overcome, you know, the protective mechanisms that exist within these cells. And so Matthew Davids back at our institution undertook, you know, a work looking at this new drug. It's an oral pill called ABT, or Abbott 199. There's a drug to really, for all of us to keep an eye on, it's this drug here, because in many different histologies, they found activity, but particularly in Waldenstrom's. You know, all three of the patients that they treated, you know, responded. And so, you know, we're moving forward to have this agent now looked at in a very dedicated trial in Waldenstrom's. And what I'll share with you here is that this is the kind of drug that you can really combine with other strategies, and particularly ibrutinib. You know, if I see one winning combination down the line, whether we can afford it or not will be a whole different story, is putting together ibrutinib with ABT 199. In the last moment, I just want to tell you what still keeps me up at night is why these people with wild type, you know, MYD88 do as bad as they do. And we've had a number of efforts, both ourselves as well as our colleagues in Spain and in France, that have tried to decipher, you know, what's going on in these patients. And what we have identified is mutations in this gene called MLL2. It's a interesting gene. It does a lot of different things. But you see it mutated in other lymphomas, including aggressive lymphomas. And this may be the reason why, you know, we find a very different course. And so trying to decipher out, you know, what's going on in this population of patients becomes very prudent if we're going to develop strategies to go after the disease. So I want to summarize by saying that both the MYD88 mutations and CXCR4 mutations are common in Waldenstrom's, that they actually do affect the way the disease presents. CXCR4 mutations do not impact survival, but the MYD88 status does. It defines a population of patients, particularly the ones that don't have the mutation in MYD88 at higher risk. We know that if we use more sensitive technology, we can pick up these mutations, even in IgM-MGUS, suggesting they have an early role in the disease. We know that MYD88 triggers Bruton's tyrosine kinase. We know that the BTK inhibitor is quite active in Waldenstrom's patients, and that the mutation status, both MYD88 and CXCR4, impact ibrutinib responses, and that inhibitors to both MYD88 and CXCR4, can be of use in formulating a targeted way of treating this disease. And then lastly, and this is why we should all get fired up, is these biological genomic revelations are really what are driving now, our ability to help make new drugs happen. Now, last night, when we were all, at Parliament having our closing ceremonies, I made mention of the fact that we were here in London because of the respect that we have for three key individuals who have played a monumental role in our understanding of Waldenstrom's. And when you start thinking about, what these individuals represent, they represent, brilliance, they represent compassion, and they also represent courage. And you can see that in the faces of the individuals I'm showing you here and who I know you all know and love. But also, what you see here in the face of Oz is defiance and the ability to get us, to the Emerald City, to finding a timely cure for Waldenstrom's. And that person, exemplified in the persona of Dorothy, is none other than our beloved Dr. Robert Kyle. And with that, I'll conclude and thank you for your kind attention.